Our discussion today on the announces ophthalmology and nephrology. So this is the title that AI gave me, and I kind of liked it. So Eying the kidney image is also AI. So let's wait for some right advantage. So let's start. So the objectives for today's band down is like we will understand what's the basic connection between eye and kidney, recognizing the ocular findings in CKD and ESRD patients, which are the most likely findings, exploring the retinal and renal injury in diabetes and hypertension, which we are always concerned about. Fortunately, reviewing the ocular complications after kidney treatment, specifically for transplant nephrologic people, identifying drug-induced ocular toxicities in nephrology and some future implications. So this is like a basics, just to let you guys know what we are going to see today. So anything which is like anterior to lens is anterior segment, posterior to that is posterior segment, posterior we have vitreous and retina. Macula is the one where we see everything, and anything in the visual axis is avascular. So if it becomes vascular, then we cannot see. So that's why macula is avascular, vitreous is avascular, lens, of course, and cornea. This is the fundus photograph. In the center, we see macula. This is the optic disc, always in the medial side, and the retinal artery and vein. So the thicker one will be the vein, and the thinner one will be the artery. And just for the sake of anatomy, the choroid is just behind the retina. So we may be seeing some sort of chorioretinitis. So that's when the choroid gets involved. So these are some basic terminologies that we This is the most important part. So I think the first three things we always see in the ophthalmology report, OU means both the eyes. So if findings are similar in both the eyes, then they usually write OU, D is for the right side, S for left side, VA stands for visual acuity, diabetic macular edema, clinically significant macular edema, non-proliferative VR, proliferative vitreous hemorrhage. These are the most likely questions that you are getting in USMLE, CRU, and CRDO. Retinal detachment, we all know RD, and some more thing about AMD, age-related macular degeneration.
You should share this with us honestly for just deciphering the. Each time I give it a try, then I give up in the middle of it.
You should tell us that D is dexterous as a sinister,
Yes.
right? So left is sinister.
Also, if I may ask, sometimes OS is OG. The G is gauche. This is left in French.
Oh, okay. So our first objective, understanding what's the basic connection between the both. So I got some interesting facts common in between. So basically, they are kind of structurally, developmentally, physiological. There are common pathways. So both of them have like pretty much dense vascular networks. So as choroid in the eye, we have the glomerulus. And similarly, the basement membrane that we see with type 4 collagen, we do have similar thing in the retina. And there is a RAS system active in both the things. This has like more localized RAS than more systemic in kidneys. So that they call it as common soil hypothesis in one of the articles. So they share like kind of common risk factors and pathogenic mechanisms. So age-related changes, which we see in eye as like cataract, age-related macular degeneration, glaucoma, retinal vascular changes, similar vascular changes happens in kidneys, smoking, risk factor for cataract, age-related macular degeneration. So we started seeing like nomenclature, so we just ready for that. Diabetes, glaucoma, diabetic retinopathy, retinal vascular changes, hypertension, obesity, hyperlipidemia. So AMD is kind of common for everything in eye. And these are the common pathogenic mechanisms like gene-related disorder, cardiometabolic risk factors that we discussed, oxidative stress, microvascular dysfunction is the one which plays the most important role in diabetes, having both complication and atherosclerosis in hyperlipidemia and smokers. So there are some common risk factors. Just to let you guys know, they both originate from different part of embryo, like neuroectoderm eye develop and intermediate mesoderm the kidneys. So they don't like develop from the same germ cell layer, but they are kind of like different in that regards. But there are some transcription factors, some genes which are involved in development of both the things. So we can discuss that thing. So this is the fundus finding, this is the ultrasound, and this is the question. A 9-year-old child with mild visual impairment with that fundus finding, which is showing optic nerve coloboma, and ultrasound of kidney showing bilateral small size kidneys. Any diagnosis that you guys can think of? So these are more of the connection of eyes and kidneys. So the diagnosis is here, renal coloboma syndrome, PAX2 gene, which is kind of a transcription factor regulating the both the things, optic stroke and ureteric bowel development. That's why we see common things. Everyone should be knowing this. So this is the lens, just to let you guys know. And we are seeing eye from this side, the lateral side. This is cornea, this is eye. And this patient has hearing loss and hematuria. Any thoughts? Almost. So that's Alport syndrome. Genes, as we discussed, the collagen is there in both the things. So called 48345, type 4 collagen forming the glomerular basement membrane and lens capsule. That's why we see anterior lenticonus in that. So this is the eye finding. This is slit lamp. And we see there is very residual iris here, kind of a big pupil without iris. And this is the CT scan. Any specific diagnosis that we can think of when these two things are associated? So this is Becker syndrome, Burns tumor, ESKD, proteinuria, FSGS, universal is and IDD at that patient. Cataracts, glaucoma, nystagmus can be present. So nystagmus is possible because the pupil is so big that patient is not able to focus. So that's why they eventually develop nystagmus. So PAX6 gene and WT1 gene deletion at 11, B13 level, which leads to this syndrome. Okay. And another thing. So I'm seeing this for the first time. I never saw this thing before, but this is called as cornea verticillata, and this is the posterior subcapsular cataract, and this is the angiokeratoma. Any association having all these three things common? Okay. Yeah. So GLA1 gene, which is involved in glycosphingolipid metabolism. Okay, so on the very left, we are seeing a fundus photograph. So this is like a wide fundus photograph. When we see fundus with just a direct ophthalmoscope, we usually see this and macula, and this all periphery is like the wide fundoscopic examination. So anyone knows from med school what this fundus finding is? So this is the retinitis pigmentosa. We see all the roads being like abnormal, and this is the RP, and this is any associations that you guys can think of? This is senior Loken syndrome and PHP, different mutations, basically primary ciliary structure and signaling dysfunction. Okay, one of the last this objective. So here we are seeing the retinal hematoma. It's kind of abnormal neural structure that we are seeing, and this is the CAT scan with some abnormal cyst. Any association? Yeah. This is TSC1, TSC2, mTOR pathway regulation of cell growth. So this was just an overview of how the common congenital disorders can be related to both the things, eyes and kidneys. These are all other syndromes which are less common, but I just covered the most common ones. Okay, now I'm moving to the second part of my objective, recognizing the ocular findings in CKD and ESRD patients. So why we are studying all these things? Because in CKD and ESRD patients, the visual impairment is 2 to 7 times higher than general population. Diabetic retinopathy definitely higher in CKD patients, cataract, as well as retinal vascular occlusions. So we do see some involvement. So CKD is associated with 73% high risk of developing any eye disorder. There was a database showing 2 to 7 folds higher prevalence of visual impairment and ocular disease in CKD patients. And in a Singapore population-based study, CKD was independently associated with like visual impairment, cataract, any retinopathy, and diabetic retinopathy. So eye disease occur earlier in CKD population compared to the matched controls, even without stratifying CKD severity. Despite this, substantial burden, routine screening is not the standard of care at this moment. So right now I'm covering the physical you can cover.
If you want. There's water.
So ocular manifestations of CKD and ESI without diabetic and hypertension. So this is like a conjunctival picture and showing this kind of calcification, which is also common in patients with secondary or tertiary hyperparathyroidism. Anyone recognizes what this thing is?
Pterygium.
Yeah, this is like nasal and temporal pterygium. And this is kind of like a cousin of it, which is a pinguncula. So we do see this kind of ocular manifestation being the conjunctival calcification on the first slide being the most common anterior segment finding, up to 81% hemodialysis patients. I know we don't check that much, but just an association. And this is the cornea we are seeing in slit lamp. And this is the OCT finding of a cornea from different layers. Anyone knows like what this thing is? This is seen in ESRD and CKD patients. So that's the band keratopathy common in tertiary hyperparathyroidism, basically similar calcium, phosphorus metabolism disorder. Corneal endothelial loss occurs as well. So we do see CKD patients having increased corneal thickness. And this is how we measure usually on OCT. And there have been noticed some fluctuations when we do osmotic fluorescence with hemodialysis. Okay. And everyone should know this. So this is a dilated pupil exam, and what are we seeing at right now? This is cataract. This is a mature cataract. So that's the nuclear cataract, and this is the mature cataract. These people don't see anything. They can still have some vision. So cataract CKD patients have significantly elevated risk and develop cataracts earlier than the general population.
For the previous one, does it improve or it take care of the hyperparathyroidism?
No, once it's deposited, it does not. Mm-hmm. So the conjunctival finding, you can take care of it, but once it is in cornea, you cannot. So everyone might be knowing something about glaucoma, basically increasing intraocular pressure and later on leading to optic nerve damage. So open angle glaucoma, CKD is a risk factor for the same, and acute angle closure glaucoma can occur during hemodialysis sessions due to the same fluid shifts that we are doing with the dialysis. Now this is, anyone knows? No. This is a carrier artery. This is central retinal artery occlusion. Anyone knows this? So this is the AMD that I was talking about. So they usually have this yellowish deposits, which we call as like drusen. And when they have like, so when drusen keeps on developing, the eye thinks that this is some sort of ischemia. So they do develop like effusion around the macula. So this is wet AMD and that is dry AMD. So macula is intact here. It's not. Anyone knows this? Yes, this is RD. This is retinal detachment on upper temporal area on the right eye. And this is the most common thing that we always check for in diabetic patients in the eye, or that they get the intravitreal injections. This is macular edema. So the basic of macular edema is they have the layers of retina have got some edema, and there is one other pathology that's not the case. So here the detachment occurs from RPE level, and all of the retinal layers are intact. So this is central serous retinopathy. The only reason I'm talking about all this because we have some relations with that. So retinal vascular occlusion CKD patients have twice the risk of retinal vein and artery occlusions compared to the controls. Age-related macular degeneration, AMD, is one of the most consistently associated eye diseases with CKD alongside the diabetic retinopathy. Macular edema in non-diabetic patients can also have that because of the uremia-related blood retinal barrier disruption. And serous retinopathy, ESRD patients on dialysis have 3 to 4-fold rise of serous retinal detachment. Central serous retinopathy 1.5 times higher in dialysis patients. So this is a patient who comes in with like acute vision loss in right eye with normal vision on left eye. Any specifics that we can think of? So this is optic neuritis. This is not just papillary edema. Papillary edema that usually happens bilaterally when someone has acute vision loss with one eye. So that is because of the optic neuritis. And this is a patient who has got optic atrophy. So the complete whiteout of the disc. Here there is some yellowish. So the reason why I'm talking about that is ischemic optic neuropathy that is still possible, which we see here with intradiabetic hypotension and anemia, uremic optic neuropathy rare but potentially reversible. And there is optic atrophy in post-transplant patients associated with systemic infections. Okay, so ocular manifestations of some autoimmune conditions. So GPA, scleritis, and episcleritis we most likely see there. SLE with nephritis, retinopathy, cotton wool spot, choroidopathy, and dry eye. Anyone knows what is Kino syndrome?
That's an old question for nephrology.
Tubular interstitial
Nephritis and uveitis.
So by definition, they will have 100% uveitis. Sarcoidosis will have uveitis. IgA nephropathy rarely seen as episcleritis, and I found this very unique. I never saw this before. So anti-GBM patients, they have been reported having leopard spots with choroidal thickening. So this is how we see on this exam. So these are the spots which are going on. They have the central retinopathy. This is from JAMA. Okay, so just to give you guys a brief what the difference between scleritis, episcleritis, uveitis is, this is again AI. So the most important thing is when someone has episcleritis, they don't have any vision changes and pain is very mild. When someone has uveitis, they do have vision changes and pain is moderate. And when someone has scleritis, this is kind of threatening to the vision. So we need to act on that very quickly. This is how we can see that usually on direct examination, but we do need like fundus examination. So now this is the most important third objective that we need to discuss, exploring the retinal and renal injury in diabetes and hypertension patients. So why diabetes is affecting both the things? So diabetic retinopathy and nephropathy arise from the same hyperglycemia-driven microvascular injury. There are different pathways which are involved. So basically, some sort of ongoing metabolic derangement leading to reactive metabolites, activation of cell signaling molecules, altered gene expression, protein function, and overall leading to abnormal angiogenesis, hyperpermeability, abnormal blood flow, contractility, and so on. Many things are there. They were the basic, and why they are affecting both the things. So both retina and glomerulus, they contain fenestrated capillary bed with specialized filtration barrier, like blood retinal barrier and glomerular filtration barrier. Both rely on supporting cell endothelial interaction, retinal pericytes and glomerular porocytes. Basement membrane thickening is the first thing that happens in both the organs. VEGF has been playing a dual role. Physiologically maintains the capillary integrity. So it's like not possible that the capillary integrity is there without VEGF. VEGF is always there. It becomes pathological when it drives the retinal neovascularization as well as the glomerular injury and proteinuria. There is a axis between VEGF and nitric oxide which gets impaired, leading to VEGF-mediated inflammation, permeability, and angiogenesis happening in both the places. So now we'll see some of the diabetic retinopathy changes that we always see in the ophthalmology report. So this is a regular fundus photograph on left, and this is the fluorescein angiographic photograph. So here they inject the dye, and then they start taking the photographs. So so what we're seeing here is these are the Some of them are mine. So on direct fundus examination, you cannot differentiate completely what the microaneurysms are and where are the hemorrhage spots. So we can see this are like a big spots of hemorrhage. This is the hard exudates, and this is located just on the macula. When they do the fundus photography of the same person, you can see some of the ischemic regions which are like kind of potentiating the VEGF secretions, and the cycle goes on with the neovascularization. So when we see some patients who are getting like laser photocoagulation, so they are basically ablating this spots of ischemia so that they do not cause angiogenesis. But if you see anything close by to the macula around like 500 microns, which is like this one, then you don't photocoagulate that, otherwise it will affect your vision.
This is versus in the eye or IV?
No, you inject in IV.
That is it. I had a concept from ophthalmologist in advanced CKD and with the fluorescence.
I think here the dye amount that we use, it's not that much.
It's
Like
so
very-
small the
yeah,
amount that it
yeah.
doesn't really.
But they still sometimes say they're not gonna do it.
There's a risk, and
Yeah.
there's been case reports, but
Right.
it's just so
Yeah.
minor the quantity. It's not a big concern.
And this is like a normal retina with the OC. This is the OCT finding of the retina. And this is how we see the diabetic macular edema. This is like advanced diabetic retinopathy. This is how the neovascularization looks like, the abnormal vessels, the hard exudates, hemorrhages on the macula, intraretinal hemorrhage, hard exudates. So whenever you see like hard exudates and some sort of hemorrhage going on, it means that they might be having edema. So we cannot appreciate like 2D. This is the 3D picture. And this is how the neovascularization happens. So when it happens on the disc, this is called as NVD, and other places it's called as NVP. So these are the stages of diabetic retinopathy. On the left side is non-proliferative when there is no angiogenesis at this moment, and proliferative means when there is angiogenesis going on. So these patients are prone to become PDR. So that this is the time when they do the fundus fluorescein angiography, look for the ischemic spots, and try to ablate them with the laser. And here we can do, but still, like patients are pretty advanced. And when someone has macular edema, those are the patients when they start instilling the intravitreal anti-VEGFs. So any macular edema, the treatment starts with intravitreal VEGF. So why do we care about all this? So diabetic retinopathy as a predictor for CKD progression. So when someone has diabetic retinopathy, NPDR, it increases 2.94 risk of having CKD. And when someone has PER, the risk is like 16.64 times high. Diabetic retinopathy is a strong predictor for diabetic nephropathy, as we discussed. And higher diabetic retinopathy grades are associated with more severe glomerular lesions, including Kimelson-Wilson nodules that we usually see. And how diabetic nephropathy is related to diabetic retinopathy. So whatever studies I saw, they all mentioned that when someone has albuminuria more than 300, the risk of having diabetic retinopathy goes high. So USER more than 306.7-fold risk, higher microalbuminuria, hazard ratio is 3.14. And the vision-threatening diabetic retinopathy is also again associated with proteinuria. So there were more studies which were related to the proteinuria association with the diabetic retinopathy rather than the GFR. But there was one study where they mentioned that the both of them are playing synergistic role, but there was more association with the albuminuria. Okay, so there was one study where I found that this was done in Chinese cross-sectional study with like patient population close to 27,000. There was like they mentioned that they did not find any association between one of them, like who had diabetic retinopathy may or may not have like diabetic kidney disease and other way around. So 1,752 patients had diabetic kidney disease without diabetic retinopathy. And similarly, 1,483 patients who had diabetic retinopathy without kidney disease. So, yeah.
How did they know that the patients had diabetic kidney disease?
That's
Just they don't.
absolutely.
There's no proteinuria. That doesn't mean they don't have diabetic kidney disease.
Yeah. So they mentioned that they were sharing some risk factors, including age, diabetic duration, waist circumference, A1C, and diabetic kidney disease was more strongly associated with blood pressure and triglycerides and retinopathy with lower education. But this was one study. So clinical implication was absence of diabetic retinopathy does not exclude diabetic kidney disease. It should be independently assessed from this study. That's what they come up with. Sorry. Anyone knows what we are seeing here? So this is one of the complications of diabetic retinopathy when it's in PDR phase. I think this was again a board question all the time in USMLE, but this is with assemblage. So whenever there is a PDR and it keeps on like bleeding, then everything goes into the vitreous. So there are a couple of things that we are looking at right now. So this is how we closely see the neovascularization in the retina. This is something called as GIRMA, intraretinal microvascular abnormality. And when this continues to happen, then we see the fibrotic bands within the retina. So this is how it progresses overall, the vitreous hemorrhage, then leading to traction RD. And this is kind of the end stage. When someone has neovascular glaucoma, when you see neovascularization on the iris, then the patient have like no visual prognosis. So now coming to the anti-VEGF therapy, ocular benefits and renal safety concerns. So anti-VEGF therapy. So anti-VEGF inhibits VEGF, reducing the pathologic angiogenesis and vascular permeability. Basically, that is upregulated in diabetic retinopathy, wet AMD, as we discussed, retinal vein occlusion causing neovascularization and macular edema. So anywhere where you see macular edema with any etiology, the answer is anti-VEGF. Administered intravitreally every 4 to 8 weeks, so every month usually, with 7 to 8 injections in the first year. Common agents include ranibizumab, aflibercept, bevacizumab, which is kind of off-label and cost-effective. That's why everyone is using it. Brolucizumab, faricimab, and clinical impact is that have dramatically improved the outcomes, including patients 9 times more likely to gain more vision, including 15 letters compared to the controls. That's why it's a standard of care. So this is how they usually inject, going from the plana approach. And this is the junction, and it goes right away inside the vitreous. So anti-VEGF therapy, again, the same thing. So side effects. Overall complication rate is very low. Common local side effects, including increased intraocular pressure, that we can definitely see because we are injecting something in a closed chamber in the vitreous. Serious complications include endophthalmitis, retinal detachment, vasculitis, and sustained IOP elevation. This is local. Now coming to the systemic, which is we are interested. So anti-VEGF agents enter the systemic circulation. Risk is still controversial. The events which are noted are arterial thromboembolic events. Theoretical risk, it increases MI, stroke, and hypertension. So the large real-world cohort, including 88,000 patients, did not show any significant difference among any different agents, like who is causing what. Mortality is increased, all-cause mortality in diabetic eye disease, hypertension, no significant increase noted in meta-analysis. So how much systemic absorption can lead to some renal side effects? So intravitreal anti-VEGF doses are hundreds-fold lower than what systemic doses we use for oncology purpose. So bevacizumab dose is like 400 times lower in intravitreal injection. Aflibercept is 140 times lower, and ranibizumab and others have not been used in oncology purposes. So bevacizumab has highest systemic exposure after the intravitreal injection. It peaks 9 times higher than the concentration, 3 times higher trough concentration. So basically, the highest systemic absorption is for bevacizumab. Intermediate seen with aflibercept and ranibizumab has the lowest systemic exposure noted so far. So these are some studies and case reports that I went through. So basically, anyone knows what Goldilocks problem is? I did not know until I read through that thing from my mother. So basically, Goldilocks was the one who was finding the right thing. So VEGF is the one which not good in excessive or less amount. It should be in right amount. So there have been these are the case reports which are telling us that anti-VEGF has been linked to some sort of kidney dysfunction. So the first case report came out to be in 2011, where ranibizumab was proven to cause renal TMA after intravitreal injection, first biopsy proven case. Then the next one came back in 2020. There were 3 patients with bevacizumab and aflibercept. TMA developed 6 to 11 months after the therapy, and proteinuria was the first sign. Then again, some case reports with the similar medication. The reason was noted collapsing FSGS, nephrotic syndrome after stopping aflibercept, which was resolved. Then some case reports with ranibizumab causing MPGN, and bevacizumab was noted to have TMA and collapsing FSGS. So overall, all of them have been contributed to cause TMA in this case reports. Now come, yes.
Sorry, can you go back? For 2020 report, how long does aflibercept last in the
In
body?
the system? I do. So basically, they accumulate over the repeated dosing. I don't have a specific like how long it stays in there because no one checks that long. Like if they are coming to you, like I'm not sure if they were checking the levels that much.
What's the frequency of exposure? How often?
So I think
They give it some
every month over like 7 to 8 injections.
But the effect, like drug may be in the body for a shorter period, but the anti-VEGF effect lasts longer. Like even in oncology, they give it every month, but if you have proteinuria, I mean, biopsy-proven TMA, it takes months to go away. The effect doesn't go away. So that's a treatment, right? More internal.
If this is a biological agent, is there a sort of is there a problem with the pharmacological properties, which is is the dose what it is saying on this? Like what are those quality checks? Like could the be like the monoclonal antibody levels or the amount just be not well quality controlled or something? Because they're at the end of the day biological agents, so there is only cross-checking so many times. It's not a chemical agent which is measured like so. Is it like can that go up and down? I mean, I'm just asking, right?
I'm not sure.
One thing if they check for complement genes or antibodies, and this was just a second hit on underlying abnormality in these cases.
It's just that after therapy, 11 months after therapy, right? It's monoclonal antibody, right? The first one, and the second one, is it an antibody? Or what is the
Yeah, it's just an element, not the whole antibody.
Okay.
But it's also, I mean, 6 to 11 months is when it's detected. Could have been there earlier and wasn't detected. And then, as was said, TMAs take a long time after the initial hit to resolve.
And I think we might have meant after starting therapy, maybe not after the last dose, right? So
After starting with lows.
These are some studies which are done for a similar purpose. So first study came out to be in 2022 with this retrospective study, including 625 diabetic retinopathy patients receiving anti-VEGF. So the major finding was eGFR less than or equal to 30 was associated with accelerated renal decline. But study had advanced systemic illness and incomplete renal follow-ups, and it was an observational design. In 2023, population-based database study, which included diabetic population exposed to intravitreal anti-VEGF over 5 years. So for those patients, anti-VEGF was associated with 1.8 times or higher odds of kidney disease, but biopsy data was not available, so causality was not directly proven. In 2023, there was a systemic review and meta-analysis where they had randomized controlled trials comparing intravitreal anti-VEGF versus the control, and they did not find any AKI increase overall. So advanced CKD patients were largely excluded on many of the trials where they did the meta-analysis. In 2024, retrospective comparative cohort study came out and it showed eGFR decline 10 versus 1.5 and 17% required for dialysis, but it was a small sample size, just 45 patients. In 2025, I think Dr. Shana discussed this thing yesterday. So they basically made a registry of all the case reports and case studies where the intravitreal injections were causing TAS, but many of them did not have any like biopsy proven thing, and it was just going through all the cases they were reported, they were just making a registry out of it. So in 2025, systemic review and meta-analysis was done. They included all possible intravitreal measures, and out of those, only the bevacizumab was shown to have highest amount of AK and hematuria. But it was still not the case that they have any specific things going on in the kidneys. This is the only outcome they noted. So,
Can I?
yeah.
There was a recent article published about meta-analysis. Like, our meta-analysis always appropriate for the specific topic. There's an explosion of meta-analysis, especially with AI software being available. I mean, you mentioned earlier the dose we use of bevacizumab or others is like 1 milligram compared to 1,000 milligram used in systemic doses. Sounds like case reports which are biopsy-proven TMA are like 7 or 10, which are biopsy-proven. Sounds like it's an idiosyncratic if it is even true. If we have an idiosyncratic side effect in thousands of patients, is it appropriate to even look in meta-analysis and say there is high risk or not? I mean, these patients have diabetic proliferative retinopathy. They're going to have high risk of problems if you look at a bigger retrospective data analysis, right? I mean, so difficult to make any conclusion out of these large data sets. I'm just curious.
I would also say it's difficult to say the safety from randomized controlled trials because they have a good set, nice exclusion criteria to make sure they don't run into adverse events.
I wonder how can it just because severe neuropathy is medications, and that creates with severe, diabetic nephropathy and increases kidney disease. How you can adjust for that and say this is just, it's a bad case from
publication.
And publication looks from AI. On that line, like just being the devil's advocate, like is the incidence here more than the incidence in general population?
True. So I think the conclusions that I came up with, they should be worked out. So they should be monitored, blood pressure, urine analysis, and urea.
I think we agree.
So no, because like when GFR is less than 30, they are the most vulnerable population, which were like excluded kind of from all the studies. And if we see new or worsening proteinuria, hypertension, rising creatinine, then many of the case reports, they just held the medication, and over the period of time, the TMA, which was reported biopsy proven, started getting installed. And if it is suspected, then renal biopsy can go wrong, and discontinuation of medication leads to improvement. So when possible, like this is not we are going to decide, but these are the medication proven to have less effects on the kidneys compared to the bevacizumab, which is proven to have like for systemic as well as the intravitreal injections. Now, there was one thing that I just found something useful. So rapid correction in A1C with GLP-1 analogs, liraglutide, semaglutide, dulaglutide, they have shown to have worsening diabetic retinopathy in randomized control trial. There was conflicting data on GLP-1 receptor agonist on non-arthritic ischemic AI neuropathy and neovascular age-related macular degeneration with fresh cohorts, but data was limited. There was an association between GLP-1 and lower intraocular pressure as well as physics. So the only important thing I noted that rapid correction can lead to worsening of the diabetes.
Do you know the mechanism? Because I had a case and then it was, you never can take the GLP-1 anymore because it really could worse. Do you know?
No, I did not come through like any article suggesting what is like actual hypothesis. So now coming to hypertension side. So eyes and kidneys in hypertension, they are deeply interconnected, sharing the microvascular pathophysiology, and they both are kind of end organ with similar vascular anatomy. So we'll have some fundus findings that we can look for in eyes. So there are 4 things that I'm showing right now. So this is like diffuse vascular narrowing that we are seeing in high blood pressure patients. This is, we can see like the localized narrowing of the arteries. when the arteries are narrowing the next to it, like the vein, they will have some compression on top of it. This is called as AV leaking. And this is the copper wiring or silver wiring that we see in severe high blood pressure patients. Any specifics what this thing is? This is malignant hypertension. We always talk about. This is papilloedema. And what is this? So the star that we are seeing on macula, that's called as a macular star. So these are different stages of hypertensive retinopathy. As it goes, like as I shown in the previous slide, then it is like arterial narrowing, it's mild, AV leaking at that time becomes moderate. Then we start seeing like dot and blot hemorrhages. Severe is the one when we start seeing arterial, the hard exudates, flame-shaped hemorrhages, macular scar, kind of advanced and malignant, and papilloedema. So now this is again a thing that we discussed before. Anyone knows what this is? So this is a patient with severe high blood pressure coming with loss of vision. So this is central retinal vein occlusion, and you see macular edema in the same patient. And this is kind of a branch retinal vein occlusion when that AV leaking causes the venous congestion to happen and the veins just gets closed. Okay, so why we are discussing all this? Okay. So the final conclusion out of all these studies is when someone has retinopathy in general population, their risk of having kidney dysfunction is very high. Not in the already known ESRD or CKD patients. Out of all these studies, that is what the conclusion is. So retinopathy, the first study, retinopathy science independently predicted the new onset of renal dysfunction. Retinopathy 3.2 times renal dysfunction duration over 4 years, predicted the new CKD, and it was kind of synergistic with the albuminuria. So when they adjusted for GFR and proteinuria in these other studies, they did not find it significant for ESRD or CKD node patients. When it is just for general population, the finding of hypertensive retinopathy is helpful. So that is my again takeaway for the same. So microvasculature, which can be seen in vivo, that's why it's important to us. Retinopathy predicts a new onset of CKD in general population, not in ESRD. 45% CKD patients have ocular pathology that needed ophthalmologic follow-up. 25% have retinopathy, 3 times higher when GFR is less than 30. And the retinopathy and albuminuria are synergistic. So when both present, they are at high risk and call for aggressive management. So now this is a thing for kidney transplant people. So why we are worried about all this? So there are a couple of complications that we see after having a solid organ kidney transplant. So the most important that I thought is first is conjunctiva ocular surface squamous neoplasia, which is like high in risk after transplantation, more aggressive clinical behavior in immunosuppressed patients. Posterior subcapsular cataract is one of the most common vision changes problems with patients being on steroids and CNIs. Steroid-induced glaucoma seen 5 to 20%, even with low dose of steroids. And what happens in retina? So hypertensive retinopathy, 20 to 52% associated with poorer graft function and longer dialysis duration pre-transplant. So after transplant, it's something not new that is happening, but like how long they were before on dialysis and how good the graft is. That's how it depends on the hypertensive retinopathy. For diabetic retinopathy, it's kind of the same. Risk is high with prolonged diabetes exposure before transplant. And this is something I knew came up like tacrolimus-induced optic neuropathy, rare but potentially finding complication. May have despite therapeutic tacrolimus. Anyone knows what this is? Yeah, so what if this patient comes in without this rash, but this finding on street lamp? So that will be HSV, this is VCV, varicella zoster. If there is just corneal ulcer without skin rash, that's herpes simplex. Now, anyone knows about this? CMV retinitis. And any thoughts on this? Everyone is having vision loss. So the basic thing here is like CMV retinitis, CMV is the cause, seen in like close to 20 days after having transplant. The classic appearance is hemorrhagic tears by retina, treatment with valganciclovir maintained on the same. If they are having retinal detachment, then we should be going for vitrectomy and toxoplasma 87 days after the transplant, but it is seen in seropositive kidney transplant patients. The appearance is head-like in fog, that what we saw. It has retinochoroiditis, treatment with Bactrim, similarly prophylaxis. Prognosis is favorable, but poor in CME retinitis patients. So what I saw for CME retinitis is highest risk when donor is positive, recipient is negative. Most other risk factors, diabetes and ATG, patients who got induction with ATG, and 80% of them are asymptomatic at the time of diagnosis. So that's why routine dilated fundus examination when they are having viremia should be done. This is kind of like I just wanted to touch base for this acute retinal necrosis, which is kind of a painful and vision loss life-threatening condition. And when we see progressive outer retinal necrosis because of VZV, that is not as painful, but like prognosis is like kind of poor in both the conditions. So now medications that we use in nephrology having some sort of ocular toxicities. So this person is on hydroxychloroquine. Do we know what we are saying? So this is bullseye macropathy, which is classically seen in plaque-venous patients. This is the earliest finding that we can see on OCT, rather just fundus examination. So we can see the atrophy of parafolia leading to sunken retinal tissue. It's kind of a UFO sign that we see in OCT. So what are the guidelines about the hydroxychloroquine-related retinal toxicity? So bullseye maculopathy causing irreversible retinal damage, that's why it's important. Usually most likely seen more than 20% of cases after 20 years. CKD being a major risk factor because reduced renal clearance increasing the circulating hydroxychloroquine levels, and 50% GFR reduction approximately doubles the retinopathy risk. We should be reducing the dose more than 25% when GFR hits less than 30. And the important thing is lupus nephritis are particularly vulnerable because of the renal dysfunction as we discussed, and they will need retinal exam every year after initiation, annual OCT and visual field testing. So this is the most likely complication that we see in transplant patients after being on steroids. So this is the posterior subcapsular cataract. Here we are seeing on slit lamp. So the anterior part of the lens is clear. It's just the posterior capsule, and anything if happens on the posterior capsule, that's the most vision disturbing to patients. That's why they come like pretty much early. So steroids, posterior subcapsular cataract, glaucoma, central serous retinopathy has been discussed. Tacrolimus causing optic neuropathy, cyclosporin are like known to cause cataracts, pseudotumor press syndrome. MMF, no direct toxicities, mTOR inhibitors, cataracts, and eyelid edema, hydroxychloroquine, bullseye maculopathy, and rituximab has been shown to cause some rare side effects such as uveitis, optic neuritis, CME, which is clinically significant macular edema, and press. And now some future implications, what we can do to have like better patient outcomes. So these are the conclusions that I came up with. So the retina and kidney, they are sharing the same vascular and developmental pathways as we saw, and CKD significantly increases the ocular side effects. So there is something new which is going on where they don't have to inject even dye for patients where we are doing FFA before. So this is a new thing, OCT angiogram, where they just use the rushing RBCs being as the marker of like flow, and we can see everything on OCT angio without any exposure to IV contrast. So retinal vessel density we can see on OCT angio, which correlates with eGFR decline and may become a non-invasive CKD monitoring tool. AI-based screening, retinal imaging with deep learning can simultaneously predict the CKD, diabetic retinopathy, and cardiovascular risk. We are already working on it. So eye monitoring, there should be some fluctuations supporting ophthalmic surveillance in ESRD, but I think the impact is not that much. SGLT2 inhibitors may protect against diabetic retinal disease. which is right now not much proven. And as we discussed, GLP-1 can worsen the retinopathy. HCQ, like hydroxychloroquine, that's what we discussed, requires annual retinal screening. Ocular renal syndrome may have common manifestations, which are valuable. We need to look for that. And integrated referral model where we can work in collaboration with the ophthalmology for CKD, hydroxychloroquine, which we already are doing, CME viremia when they are complaining of vision, because vision loss will not be there in 80% of cases. And this, this is my own photograph from. No, this is not it.
Yes, you generator.
Yeah, thank you for the presentation. It was one of my interests.
Oh.
I am not a doctor, I am an AI person.
Okay.
So my question is that I did some research to see what is the connection between eye and kidney, and also I saw the same pattern in your presentation. You just showed us the eye images and the kidney functionality based on the clinical things. Do you think that is there any connection between the kidney images and eye images?
So I think like in terms of kidney images, we are kind of limited with the ultrasound and CT scan. We cannot directly look for the vascular changes and pathological changes which are
And
going
even
on.
with bio,
Yeah, we can
that's
do
such a
biopsy.
4 out of 2 million, whereas in the
Yeah.
eye, you can look at all the endothelial cells. Much more sensitive.
Yeah, and you don't have artifact like you do the biopsy, tissues out, transportation, media storage, and you're seeing live.
Mhm.
That's all here.
And this is their like baseline examination thing that they do on all the patients when they are having diabetes and high blood pressure. So probably this is kind of a screening thing for them. So they are doing it more often than we are doing like all the imaging.
I have very nice presentation. I was just commenting that you left out the UVL.
Okay.
But anyways, I had a question. Have you heard of this entity called BDUMP? This is important from general and transplant nephrology standpoint. BDUMP, this UVL condition. So we had a very, very, very cool case in Ohio when I was around it. It's called a bilateral diffuse uveal melanocytic proliferation. So there was a liver transplant elderly lady who came with vision loss. She had a laser treatment like 2 months back, and she didn't have any kidney disease after she had a lung transplant. So we were consulted because of nephrotic range proteinuria. So basically, they diagnosed her with this condition, and the treatment was plasma exchange. And when they did a CT scan of the body, they found a small breast mass, which turned out to be ductal carcinoma and C2. Right. So there was probably membranous nephropathy going on with the sudden onset nephrotic syndrome. So this was a paraneoplastic syndrome, which improved with plasma exchange.
Okay. Even like eye findings.
Correct. We could not biopsy her, unfortunately, because of ongoing plasma exchange. But this was a paraneoplastic syndrome. And then recently this occurred to me that there was a remote kidney transplant patient who had optic neuritis in one eye. And then she suddenly presented with blindness. So there was bilateral optic neuritis. She also developed nephrotic syndrome, and she was started off plasma exchange again, some paraneoplastic syndrome. So they did a CT scan, and they found a gastric mass. So these my ocular findings. Again, paraneoplastic. She had proteinuria, sudden onset proteinuria. But this was something which was related to the eye, which I encountered.
So is ophthalmologist recommending plasma exchange in these patients as
Yes.
treatment?
Yes, ophthalmologist, and they responded to treatment. So both of these patients who had blindness, they recovered their vision.
It's an established thing for ophthalmology.
Correct.
Plasma exchange.
Correct. Yes. I think the second one you also did rituximab. So
Well, first of all, thank you so very much. That was a great presentation. When you said you were talking about the eye, I was thinking, how can he fill up 60 minutes? Perfect. Without just diabetic nephropathy. No, retinopathy. But I wanted to get back to the comment that you made about GLP and the worsening of diabetic retinopathy. I have a new friend called ChatGPT. So I asked him, what is it? First of all, apparently it's not limited to the GLP in insulin and bariatric surgery. This phenomenon has been reported and it has something to do with abrupt decrease in serum glucose level. And apparently it has something to do with retinal blood flow, VEGF, and the osmolar shift similar to what we see in dialysis patients. And apparently it first came out in the trial of SUSTAIN trial from semaglutide. So, and it apparently it's limited to semaglutide as well. My friend knows.
Thanks to hallucinate, bro.
The other one thing I don't think you discussed Fabry's disease. And it's often diagnosed by the ophthalmology.
It did, but it was just a transient thing before your guest.
He thought it's too much for us already.
Ask one more question. So you talked about microvasculature pairing between eye and kidney. If they don't use images, they don't use kidney biopsies, how they understand that, for example, neovascularization from the eye images, it is okay, but how they know from kidneys without examining images, the biopsy, I mean.
Like your point is like the way we are doing eye exam,
Yeah.
we should do it.
When you are reporting that this literature found that, for example, there are neovascularization between both. So how they know this from the kidney without images?
I think they know by the pathophysiology of diabetic retinopathy. They're looking at microalbuminuria, the progression of decline. So you don't have to biopsy every diabetic patient to understand the pathophysiology of diabetes. And when they, we call people diabetic nephropathy all the time without biopsy.
That's Ilkun's point that I guess she mentioned that how do you know that typically they're not going to get biopsy.
Well, at least there should be some criteria, right, in that study, how they defined diabetic nephropathy in those patients.
And that would be really,
Otherwise, we cannot do correlations.
Yeah.
Amazing. Thank you so much.
Are you offering to be exams in that patients?
But it's insurance.
I think like
I'll go see him and I'll.
Let's talk about this.
Okay.
Like they know it too.
Oh, yeah. You want to make sure you get all the bags.
I already get it. I will take
Taking a break.
So basically, I was an ophthalmologist back in India. Before I moved to that's why I never do like many stuff. But honestly, I did not do anything like which is involved.
So I thought one of the components of the department, they have a data set for A and B. But because I am working mostly on kidney and knowledgeable about kidney, what do you think that how do they define the new project on A and B and kidney and how information?
Oh, is it okay?